Sir, we are live now.
So, good evening, everyone. On behalf of AMR Declaration Trust, I welcome everyone who is listening to us either through Zoom link or through the YouTube channel. So, as you are all aware, we are celebrating World Antibiotic Awareness Week. As you can guess from the color of my shirt, it is blue. So, we are supposed to wear blue in this week. And now, why WHO has dedicated a full week for creating awareness about antibiotics. Issue is that we are facing a huge burden of antibiotic resistance, and although everyone prescribes antibiotics, it is we ID physicians who are safeguard of these prescriptions of antibiotics. So ID physicians are of utmost important, and we are a rare specialty, and we really want to tackle this problem of AMR. But to bring to everyone's notice, someone may be aware, someone may not be. ID physician remains a rare species in most hospitals in India, and if you see the data throughout the world, uh, ID is not a very sought after specialty either. So now, if I say ID is a great specialty, everyone should join it. It will look like a sugar-coated statement, and probably you might just pass away that statement. So, in order to understand the specialty in a true way, we need to bring out the true nature of ID as a subspecialty and what is the scope of ID specialists in day-to-day hospital environment. So, keeping this in background, AMA Declaration Trust has planned this webinar in which we will be discussing past, present, and future of ID as a subspecialty. To begin with, I will welcome you all. I am Dr. Nitin, an ID physician at Rajiv Gandhi Cancer Hospital in Delhi. I will be moderating this session. And to start with, we'll play a recorded version of Dr. Chandrasekhar's interview with us, which we recorded a few days back on the same topic. And then we will give a live discussion with three esteemed panelists. And hopefully, Dr. Chandra will also join us live for the discussion. I'll introduce the panelists as we move along. So, first of all, let's begin with the interview with Dr. Chandra. Kushal, can you play the interview?
Yes.
Hello, everyone. It is indeed my great pleasure to welcome you all for this fireside chat organized by AMR Declaration Trust. I am Dr. Nitin Bansal. I am an infectious disease physician at Rajiv Gandhi Cancer Institute, Delhi. We at AMR Declaration Trust have been doing various fireside chats. These are informal sessions in which we invite prominent members of our society and chat with them or her. Mind you, this is not a scientific session, and we won't be discussing any guidelines, papers, or giving any recommendations to the listeners. And today we have a very special guest from all the way from United States, Dr. P. Chandrasekhar. He is Chief of Division of ID at Wayne State University, Detroit. I was fortunate enough to round with him in 2017 for a very brief period of time. And one of the prominent memories which I have of him is that I was sitting at the Detroit airport, waiting to board my flight to Delhi, and I just thought, what can I take home from here? And I realized that I think what I should do is that I want to be like him. That's how I would describe those 3 weeks or so which I spent with him. And I found him that he was very thorough. He was the way he spoke to his patients and to his colleagues was very, very different and unique, which I found. And I thought I could inspire I could get inspired from him in that way. So he has been a very, I will refrain myself from giving him any title like he's the father of ID in India and all these things. But I would say that he is not no less than that also. He has been a guiding angel to our society, to many of the ID physicians in India. And I can proudly say that he has taught ID to many of my teachers. So I welcome him for this session. And today we are going to discuss with him regarding a very important but somehow I feel a relatively neglected topic in Indian ID society meetings and all. That is past, present, and future of ID as a subspecialty. Now ID has started to grow, and ID still remains a new subspecialty. But still, we need to know what happened in the past. How did ID got started in all across the world, in US and all, and then what is the present status of ID in US, and then how can we move forward from there? So I would like to welcome sir. Hello sir, how are you doing?
Hi Nitin, I'm doing fine. It's a nice morning here in November. Thank you for inviting me as a guest to this fireside chat. I'm delighted to be here. And as you said, this is an important area for those of us who are involved in the field of infectious disease, regardless of where we practice, United States, India, or wherever. This is a very, very important time to talk about this topic.
Sir, I mean, you before we start the formal way, like you suggested, we divide the time into 3 hours: past, present, and future. I just wanted to, just for the benefit of the listeners who will be listening to us, many of them may not be aware of what IDS specialty is. So just to be very short, can you describe what is your typical day in your clinic or in your office? How do you spend your day? What side of patients do you see? How much time do you devote to them? And then like that, can you just briefly describe? Then obviously we will get into detail, much more detail.
Yeah. ID physician life in America is somewhat different from an ID physician life in India. I'm privileged to have seen both sides, so I'm able to speak on this topic. ID in America, my case is a little different because I do a lot of administrative work because of the position I'm in right now. But an average ID physician does not do much administrative work. They do mostly clinical work. So let's talk about an average ID physician here, what he does in the clinical side. So when they come in the morning, they usually have, it depends whether they are in private practice or on the academic side. If they are on the private practice side, they may have a nurse practitioner or a nurse helping them, or they may be on their own in solo practice, depending on how wealthy their practice is, how comfortable they are, whether they're able to hire somebody else. So let's say if they are in partnership with another ID person, then they would come in the morning and they will look for the consults. They come to their office. The office secretary will tell them these are the consults that have been called in, and then the ID physicians will split the consults and they'll be on their way to see the patients. So when they go to see the patients, they would have to extract the information from the computer, chart, and then go to the bedside, examine the patient, then go to the X-ray department or look at the X-rays on the computer itself, look through the labs, if necessary, take a walk to the micro lab to talk to the microbiology guys, and then come back to the bedside and provide a diagnosis and a plan. Explain it to the patient, and in addition, explain it to the team or the physician that consulted them in the first place. Most ID physicians do not have primary care practice. Most of them are consultative practice. So we would be invited by some other physician to see their patients, usually in the hospital setting. And most of our ID practitioners may have an outpatient clinic, and the outpatient clinic may be a half a day a week or 2 half days a week, where they would go in and follow up their inpatients who may have been discharged, or new patients like a new HIV patient and such on the outpatient side. And so on an average, the private practitioner works anywhere from 10 to 12 hours a day.
And what is the number of patients we expect that private practitioner maybe you may be seeing in your relatively younger days, if I may say so?
In the private practice side, the number of patients they might carry maybe anywhere from 20 to 30 patients in their list. And out of that, there may be 5 to 7 patients new, and the others would be follow-ups. On the academic side, where I have been for the last 40 years, is totally different. I have fellows with me to see patients. I have other ID faculty members. So we've divided up the hospital setup into 3 or 4 areas. My area is exclusively cancer and transplant, as you may remember. And when we have the teams, we have an ID team that will consist of me as the team leader. And then there would be a fellow who may be a first-year fellow or a second-year fellow. We will have 1 or 2 medicine residents who are rotating through our division of infectious disease. And we may have a pharmacist, ID pharmacist, and there may be medical students rotating. So this would be the entire team. So the team will come in the morning. They will go and see the patients under the leadership of the fellow, somewhat similar to what happens in your place, I would imagine. And then once the fellow is all ready with the cases, he will alert the attending and say, we are ready to round. So my rounds usually will start at about 11:30 in the morning after I've taken care of my administrative responsibilities. And then the rounds go on till about 2:30 or 3. And then we break up, and then we take a break. And if necessary, we would reconvene if there are any emergent consults or urgent issues to be dealt with. Otherwise, I leave it up to the fellows to sit in front of their computer, finish their electronic records, and those records will come to me late in the evening. Then I will have to read through them and sign each of those notes.
Okay, sir. So I think we will begin with the first part of our session, the past. And
Okay.
I would like to ask you to please go back into your memories and probably bring some pearls out of that. So just to give an introduction, ID, I mean, I took up ID, I joined ID as a fellow in 2016. And just to give a context to what I'm trying to come to, and at that time when I graduated from my, I did my medicine residency in Delhi. And there was, I didn't have any guidance, what is an ID specialty, whom to call, whom not to call. I mean, we didn't know anything about ID. What does ID do? What is the role of ID specialist in a hospital, in a private setup? We didn't have anything. What is the pay scale? How should I be studying ID, preparing ID for that matter? And I vaguely remember I mailed a lot of people in just mailing them just to know how to get into these programs. So it's a fairly new specialty in India, at least in northern part of the country. And whatever we have, obviously the number of ID specialists have grown in India also, but they're largely concentrated in southern part of the country like Chennai, Vellore, Pune, Mumbai, Ahmedabad, and all these places. Places like Delhi, Bangalore, and other cities have started coming up with ID, but it largely remains an unknown specialty. And I remember when I came back from Chennai to find jobs in Delhi, I struggled a lot because most of the administrative people who run the hospital do not know what is an ID specialist do. So they just look at the CV and they say, we don't know what is the specialty. That is the kind of background I wanted to give. So how did ID start in US or other parts of the world? You must be aware, sir. How old is ID in US or maybe European countries also?
Yeah, ID is not a very old branch in comparison to cardiology or nephrology or pulmonary medicine. ID started, those specialties had existed way before ID. And ID started in the 60s. Okay. In the 60s, what happened in this country was slowly antibiotics were coming out, newer antibiotics were coming out, and there was a revolution taking place in terms of infections and their management. HIV was not there at that time. This is way before the HIV time. So gradually, people began to realize that infections, particularly hospital infections, Lyme-related infections, bacteremias, things that are happening while patients are in the hospital for something else. And antibiotics were coming out quite a lot at that time, gradually. And so people began to realize maybe there should be a specialization in infectious disease field to deal with the hospital infections, and thus began infectious diseases, a specialty in the US in the mid to late 60s and early 70s. So at that time, there was no board examination, and many of the senior physicians who were interested in ID became self-styled ID guys, just like many of the guys in India. I know many of my friends who never did formal training, but they're practicing ID. So like that, there were people here who, out of their own interest, gathered together, and mostly in Boston area. And there was a group of people who said, we are interested in ID, and thus began ID. Okay, and then the 70s, it began to develop further. I joined as an ID person in 1981. 81 was my entry into ID as a fellow, and that is 40 plus years ago. But at that time, already ID was board certified specialty. So it grew in the 70s very rapidly. At that time, when I started, there were about 4,000 ID specialists in the country, board certified. And now there aren't that many. How many do you think now there are? ID board specialized, board certified specialists in America.
I think there must be, sir, we are looking at somewhere near 100,000, sir.
10,000.
10,000.
Yeah, not 100,000.
Oh,
10,000.
that's quite a low number, sir.
Very low number. Yeah. Very low number. So it has increased compared to where we were in the 70s and 80s, but it's not dramatic. So every year they put out a few ID based on the various programs. We offer as a whole country, there are about 350 to 400 spots offered for training each year. So you can imagine over a period of time, we have gathered a few thousand people, and now we are about 10,000. It is anticipated in the next 10 years or so, we should have another 5,000 or so people, but we will be falling short, projecting from where we are now. There will be a major need for infectious disease doctors in this country, as we are experiencing now. Now, if you look at most of the ID doctors want to live in the cities. So if you go to the rural areas, just like in India, rural areas desperately need ID physicians. There are many. There was a survey done recently and published in the Annals of Internal Medicine. 80% of the counties, US counties, do not have a single ID physician.
I guess we can say 80% of the cities in Delhi, in India, do not have ID physicians.
There you go. Right, right.
So we are just like a neonate in the world of ID.
You're just a few years behind.
Yeah.
Very, very similar. And I think when I travel to India and come here, I see exactly where US was 20 years ago, what I see in India now in terms of ID as a subspecialty.
I remember reading a book, sir, by Dr. Abraham Varghese. I think you must have also gone through that book, My Own Country, in which he describes his HIV, how he became I think he's an ID physician, sir. He describes his HIV patients and all. And I read that book, I think before I joined fellowship in ID. And I always wondered that I always equated ID means management of immunocompromised patients, HIV patients in particular. So it is intriguing for me to listen that ID existed even before HIV came in. So that itself is a big shock for us. We can't imagine our practice going on without immunocompromised patients, without HIV. I mean, as a general thing, obviously we see a lot of general ID also, but still having no HIV, having ID specialty without the HIV, I mean, the discovery of HIV or the HIV infection being found out, or maybe lesser number of transplants going on at that time, it itself a achievement for me to even talk about it. I mean,
right.
That way.
Absolutely right. Those days, before my training was 1981 through 83, 1980 through 1983. If you remember, that's the exact time HIV hit the United States at that time. We did not have a name for HIV at that time. We saw a few patients during my training. I saw a patient with pneumocystis. I had no idea why the patient had pneumocystis. And that was my first case of pneumocystis. I had never seen a patient with pneumocystis. I saw a patient with cryptosporidium, diarrhea, and patient was losing so much fluid, reminded me of cholera when I was a medical student in Vellore. So this was incredible at that time. But prior to that, ID had started in the 70s. What did they do? What did our forefathers of ID talk about before HIV? It was endocarditis. It was endocarditis, bacteremias, osteomyelitis, and many of the skin and soft tissue infections, and very unusual infections related to diabetic patients. Cancer was not a big deal at that time in terms of infectious complications, okay, because we didn't have too many antibiotics. They were just coming out. In my time, the third generation cephalosporins came out. Okay, imagine before that, all we had was Caflex, okay, tetracyclines, chloramphenicol, and a few of the beta-lactams, penicillins, and that was it. Aminoglycoside came later. So the revolution began in the 70s and 80s in terms of antibiotic revolution. But by the time we were making diagnoses and we were taking care of patients with bloodstream infections and endocarditis in particular. And it was incredible. If you sit and listen to those guys giving lectures without any slides, stand up in a podium and talk for an hour. I listened to a guy named Louis Weinstein. Louis Weinstein, if you look up the ID history books, he's one of our forefathers in Boston. Okay, he's a brilliant man to listen to. And he gave a lecture. He came to Detroit and he stood up, and he was in his late 70s at that time. He stood up and gave a lecture without a single slide, and he spoke for 3 hours. He spoke for 1 hour. He said, let's take a break. We'll do part 2 of endocarditis after the break. And nobody left in the audience because it was like listening to a story, watching Shahir, one of those Khan movies.
Actually, you suggested one of the books, The One Good Doctor, in one of your Chandra's Corner, which you write for the SITS newsletter. And
yes.
I read that after I came back from Detroit. I mean, started reading at that time, and then I came back, read it, and in which the one of the, the author is the son of that doctor. He describes how his father used to write notes about infective endocarditis, bacteremias, and all these things. And he used to be in love with those notes and used to describe them like they are like poetic for him. And that's how he learned a lot of medicine from his father's notes of his patients.
Yes. Infectious disease guys are always good in documentation, taking a good history, paying attention to details. What kind of pets does a person have? What kind of travels has the person done? Such details you will not find in any other specialist's history and physical. That's why in America, when a patient comes in, if it's a complicated patient, the first thing the guys do is to call for an ID consult. So they'll have a decent H&P in the chart.
That's actually quite true. I mean, anywhere, wherever there is an ID specialist, they will call him for the complicated cases. Even if they know that it may not be an infection, still they will call him. Call him or her, let him see, let the guy document the history and all, and then we will come take over. That's quite common, sir. So how did you get into ID, sir? Is it your first love or it was the best? How did you choose ID as a specialty at that time?
I was finishing my residency, and I was in Kentucky at that time, University of Louisville. It's a good place. And there was a mentor there who was an ID specialist who happened to be a lawyer as well. He was practicing law, and he was the chief of ID at the University of Louisville at that time, Marty Raff. And then he told me, you should do ID. You seem to have a knack for it. So I didn't know about ID, just like what you said. I did not know there was a branch called ID. I knew hematology, oncology, cardiology, GI, all the traditional specialties, but I did not know ID. My first exposure was when I went to University of Louisville, and I was training with him. And then I said, oh, this looks like a good one. And I was also not good with my hands. So I knew I'm not going to do procedure-oriented specialties. So I said, okay. So by elimination, it was not too difficult to arrive at ID. Okay. So, but anyway, I loved ID. rounding with that man, and that was an inspiration for me. And it was relatively easy to get into ID, especially as a foreign student in India, in the United States, after my residency, because getting into cardiology or GI is very competitive. Those very difficult to get into those specialties. ID was not a difficult specialty to get into. This was 1980, early 1980. So I went to Philadelphia for my fellowship training. And that was a new program, and there were two of us. We started the fellowship training there. And I did my 2-year training. My partner, who was the other fellow, he went down to MD Anderson to work with the cancer patients. And then I was looking for a job, and I wanted to be in academics. It was very clear in my mind. I did not want to do private practice. I did not know how to handle money. And so I said, okay, who's going to give me a job? So I was invited for an interview here at Wayne State. So I came here in 1983, and this is my one and only employer. I've been here ever since.
So you have been here for probably half of your life, I think.
Correct. Not quite, more than half.
So one relatively tough question, I think, in that way. Do you ever regret your decision of getting into ID? Did you ever feel that?
No, not at all. I hope a lot of youngsters are watching this. Please, you would love ID. I fell in love with ID right from the beginning. And every day I wake up, I love to come to work. I love to be with people here, talking about the cases, talking about projects, talking about global health, talking about youngsters, talking about different areas. Now, the most fascinating thing now, Nitin, I don't know if you were paying attention to the ID week 2 weeks ago in Boston. Incredible how climate changes have impacted infections around the world. It's fascinating. Now, we're having our Michigan ID Society meeting tomorrow. I'm the Michigan State President. And at this meeting, we're talking about how we have begun to see malaria in America. We have malaria, dengue, chikungunya, everything is in America, in the United States, because of the climate changes in the South, and what is considered as tropical diseases are becoming temperate diseases. Diseases are moving northward. So there are several cases of dengue now in the United States. So we are relearning infectious diseases.
Well, I remember when I was sitting on one of those chairs, which is right behind you. You told that I can't. I have not managed any patients of tetanus, complicated malaria, so I can't call myself an ID specialist. And I recall, then I thought, then he's such a down-to-earth person that in front of the fellows and an observer, he's accepting that I can't do. I have not seen these kinds of patients, but I think it's good that in that way that the spectrum of the diseases is increasing in your place as well, sir. But
Yeah.
I mean, coming to India, sir, I think I totally agree with you that I've also, I mean, I am obviously just a neonate in front of you, but what I can say is that I've never regretted my decision of getting into ID. From that way, is you always have a case to discuss at the end of the day, which is something fascinating which you have discovered. And you will note that the one thing which we'll note that is a very simple fact which has been missing from the history or from the review of charts. Suddenly you will pick up that, and then suddenly the case gets solved, which nobody is able to pick up. That's how ID specialists are trained. Those eyes are trained in such a way that you pick up those small little things from the review of charts, from the patient's history, how they speak. Sometimes the attendants want to speak something, but we generally cut them out. And then you suddenly go back again, and then they speak about something which we give us a clue on what is going on with the patient. So that is definitely fascinating.
You're right, absolutely right. ID is probably one of the few subspecialties left where there is a true joy and a challenge in practicing. And we are not completely sacrificed our specialty to technology. There is still a role for bedside medicine, sitting down and taking an accurate history. observing the patient and the family and their interaction, walking down to radiology and discussing with radiology the clinical component and providing that information and exchanging that information, talking to different subspecialists, walking to the micro lab, looking at the plates, giving the microbiologist some clinical information, and coming to a meaningful conclusion. So we tie all the loose ends and we provide the story. There is no other specialty that is expected to do that, and therefore they don't do that. And they don't have the time, they don't have the expertise to do that. We are basically internists. We pay attention to all the details of all the different systems, and we try to find meaningfulness in each of those little details and try to tie all the loose ends together. And that's what ultimately is medicine all about. And that kind of a joy you cannot get from cardiology or GI or surgery. I see patients who have had double lung transplants after COVID. And imagine the joy of the double lung transplant surgeon. And that surgeon was trained in CMC Vellore in India. Now he's practicing in Northwestern in Chicago. So he has done a whole bunch of lung transplants in COVID-affected patients who had terminal lung disease. Imagine the joy and thrill he must have of performing these surgeries. But I can match that and say, every day after work when I go, I can think of my cases and say, wow, that was fascinating. I helped in trying to solve that puzzle. I provided relief for that patient's family by giving an idea how the problem began and how we can put an end to it.
I will just describe one case which I saw last week, sir. I also work in a cancer center and exclusively in a cancer center. We saw one patient who had just got back to his native place after getting his 6 R-CHOPs for a non-Hodgkin's lymphoma. He came back with, I think, 2 weeks after that after the last chemo with history of fever. And they had the hematology guys have done all the things. They have done the cultures, they have done the CT chest, CT abdomen, everything was normal, nothing was coming up. So they just asked me to see, can you just see him? So I just took one history. I just asked him, where do you live? He just said, I live in railway quarters. I said, are there a lot of vegetations around? Do you roam around? Yes, he said, doctor said, you have completed your chemo, you can do whatever you want, you live your life. So I started going out for a morning walk. I also go out for an evening walk. And I just stripped him off his shirt, and we saw the scar. And I was delighted because something which is immediately picked up, no complicated tests required. Just like you said, some basic clinical bedside medicine itself got up the diagnosis. So this is something which I saw last week. So I thought maybe it will give a context to what you're trying to say.
Yeah. And I think in India, let's talk about the ID specialist in India. It's a problem because compensation is an issue. Time is the bigger issue. When I come to India, I find people are extremely busy during the daytime. The ID clinicians or physicians in general, they see a lot more patients than what we see here. And as a result, I'm afraid the quality of care may be compromised. You're rushing, and you do not have time to sit next to the patient at the bedside, have a detailed questions asked, and try to solve the problem. So this is a challenge for every physician. On the one hand, you have to see X number of patients to make decent amount of money. On the other hand, you have to allot a decent amount of time for each patient, because even if you have a diagnosis, to explain to the patient, it takes time, and they are looking for your time. So how do you juggle between the two? And younger physicians will say, why do I have to struggle with this? I'll go do gastroenterology and do endoscopies and make my money. And I don't need to do this. So ID is a branch you need to be dedicated to. You need to want to do this. You need to be a people person. You need to be a good communicator. And if you don't have those kinds of qualities, probably you should not do ID. ID physicians should, there is a tremendous amount of challenge and joy, and you're never going to make a whole lot of money.
I think
You know,
what I will say, sir, that one I learned it from one of my teachers is that if your sole purpose of coming to medicine was to make money, then you should never choose ID.
right. That's true in the United States too.
I think that will remain true throughout the world. I think wherever we travel,
Right.
going to remain.
Right. Yes. As long as you want to practice good medicine, sitting next to the patient, talking to the patient, that's going to take up time.
Yeah.
And therefore you can't make too much money because you're going to spend time with each patient, talking to the family and making sure they understand what the problem is, making sure you understand the problem exactly. So if that is going to be your way of practicing, then you're never going to be seeing a large number of patients each day to make money. And we don't have procedures. So therefore, ID is not a branch you should come to make money. But that is not to say you're going to stop. You will make comfortable amount of money. You will live comfortably, but you should not compare yourself with a cardiothoracic surgeon or a cardiologist or a gastroenterologist. In this country, a cardiologist, a gastroenterologist, a critical care specialist will make anywhere from 2 to 3 times more money than an ID specialist. And that is a given in private practice. In academic practice, we earn even less.
Sir, I think to move on, what I will do is that I will move to the second section of our session, like the present section. Although we have briefly touched upon a lot of issues already. So
Yes.
what I will do is that I will just describe, just enumerate the number of seats which we have in India, just for the benefit of the potential ID graduates who are listening to this. We have around 52 seats of ID as of now, so 22 DM seats, 13 FNB seats, which are in the process of converting to DRNB from 2-year course to 3-year course, and 17 postdoctoral fellowships, which are not accredited to the national board, but they are accredited to either the local university or the local institute. There are around 52 seats, plus minus 10, you can say, because sometimes the accreditation may not happen immediately in the year. And you will be surprised that out of this only 52 seats, many of them are lying vacant.
Wow.
So, and we will come on to the discussion why they are lying vacant. And there are around 500 odd seats members as of now, lifetime members to say that. And I will project some of the slides which you recommended from the US, which I got. I don't have any printed or published data from India, but I do have some data from US. So I think you can see my screen, sir.
Yes, I can.
So this is the data, the graph which from your own paper, which shows the percentage of unfilled programs versus the total number of programs from 2010 to 2014, and ID is one of the top of the list. And this is from one of the papers which I found from the idsociety.org, that is IDSA's website, which
Yes.
is the number of people who are completing the ID fellowship has actually started to decline post 2013 or 2014. That's what they said.
Yes.
And
yes.
one of the major reasons which they quoted was, one of the major reasons which you quoted in your paper was that the now hospitalist is a new job which has started to come up in, which has already established in US, which has led to lesser number of people taking ID. Another thing which they also quoted was that one of them is a compensation. Another thing was that the sense of no market or less market for ID is already prevailing in US. So that is one of the few reasons why ID is not a very sought after branch in US. After you comment on this, probably I can comment on what is happening in India from a youngster point of view who just passed out from the fellowship.
Yes. You know, we, as I mentioned earlier, it is very difficult to get into cardiology, pulmonary, GI. Those are money-making specialties, so people automatically are drawn towards that. Infectious disease, traditionally, they have filled about 70% of the slots that are offered over the last several years. And then what happened, there was a decline. As you saw in 2014, there has been a gradual decline in people going into IT. This is before COVID. And after that, during 2020, there was a major dip with the COVID. People just stopped applying to IT. And then what happened, 20 to 23 or 22, the gradual improvement. This is what they call the Anthony Fauci effect. Okay, because Fauci came on TV, everybody saw him as an ID physician. So people said, oh, I want to be like him. And he was our chief ID physician for the country. And therefore, many people applied to ID. So things improved between 2020 and 2022. And now last year, 2022, once again, it has fallen down. Okay, so overall, infectious disease as a specialty in this country has not been a very sought after fellowship, at least in the last several years. One of the main reasons is compensation. As I mentioned, other specialties, you make at least 2 or 3 times more than what an infectious disease doctor would make, number one. And most, as you may or may not know, many of the people in the audience may not know, that a medical student, once they finish medical school in this country, they have a debt of about $200,000 US. They take a loan to go to medical school because medical education is not free and it's very expensive. It costs about $50,000 to $60,000 per year. So multiply that by 4. So a fresh young graduate will have a loan of about $250,000 US as they graduate. The parents cannot afford. Parents generally don't pay the fee. So the student will carry that debt as they come out. And as you know, in this country, you have to get a degree before you join medical school. So by the time a young medical graduate leaves medical school, they're in their mid to late 20s. Unlike in India, a 20-year-old can be an MBBS graduate. Here, it is impossible. You will not be an MBBS graduate here before the age of 25 or 26, because they have to do a bachelor's degree before joining MD. Okay, so now if a graduate starts with a loan of $250,000 and nobody else but they themselves have to pay for it, how can they afford another 7 years of training? Because they have to do residency first. And the residency is usually 3 to 4 years long, depending on the subspecialty. So medicine takes 3 years of training. So now they're 30 years old. Okay, they're already married and they have 1 or 2 kids. So now they have to do fellowship. And if they choose ID, they're not going to make a lot of money to pay their debts off. So there is a tremendous amount of pressure about the choice of fellowship that you would choose and not your liking. Okay, so that therefore people are turned away from IT. That is a major reason in this country. And also you mentioned the word hospitalist. There is a category of physicians. I don't know if you're familiar with hospitalist.
I am familiar, sir. I am aware what hospitalists do. Many of my friends are hospitalists who passed out with me, did MBBS with me, are hospitalists in US actually. Okay, what about in India? What is the equivalent of a hospitalist? There is no equivalent of hospitalist in India. There is either they are just internal medicine internists who not chosen to specialize themselves. So they are the one who take care of all these things, sir. Right, right. So here a hospitalist will take care of patients in the hospital. And that they get paid. And for that, they don't need anything but a general MD after your MBBS. And that general MD with a hospitalist practice makes more money than an infectious disease physician with extra years of training. So why should I do an ID training for 2 years and I end up making less money
than a guy who has just finished MBBS. So this is MD, MBBS and MD. So this has become a major issue. So compensation is one of the biggest issues today that the Infectious Disease Society of America is fighting, number one. And number two, they've also gone to the government and said, and people are not going to the rural areas. 80% of the graduates are hanging around in the urban areas. To attract all these people to different areas, they said, let's start a loan forgiveness program. So the loans that they took for education is being forgiven if they choose to do ID or if they choose to go to rural areas to practice. So they're providing incentives for people to go into ID. So IDSA is taking a lot of measures today, including the ones I mentioned, to attract young graduates to choose ID as a subspecialty.
Actually, in India, actually things are a little different. We don't have a debt issue in India. We generally, our colleges are still public, like they're public hospitals. We don't have huge amounts of fees to, I mean, I didn't pay anything, any major chunk to do my MBBS and MD. And I didn't have any debt when I passed out from my MD. I had good amount of decent amount of money in my account by the time I finished my residency.
I went to CMC Vellore as a medical student. My annual fee was 700 rupees per year.
You, sir, you did, you would have gone to CMC Vellore in 1960s or 70s. I went
Correct.
to Maulana Azad Medical College in Delhi in 2006, and my annual fees was close to 400, 500 rupees.
Yeah, unbelievable, unbelievable. Yes.
So I actually, we should be, should be grateful to the Indian government so that they have provided me such a world-class education at very, very, I mean, it's not even a rate. It's actually priceless in that way.
Yes.
So, I just wanted to discuss things of why ID is not a very chosen specialty in India also. So you discuss a lot of things about US. One of the major issues which I found, particularly in northern part of the country, is that many people are not even aware what is an ID, what is an ID specialty. Major reason is that there are no departments in teaching hospitals. There are no ID department in teaching hospitals. And most of us actually choose what our seniors choose, immediate seniors. So when none of your immediate seniors are choosing ID, you also don't choose. We generally tend to follow our immediate seniors, immediate friends or something. Another thing which I thought was that probably we are unsure about our future jobs. We are not sure whether we'll get a job after finishing my ID fellowship or not. And that is actually true. I spent around 4 or 5 months after I finished my ID fellowship without any job. So in that way, I didn't find any job immediately when I finished my fellowship. So that way it is actually true. And salary issue, I would say it is complicated in India because the compensation is very different for the way it is compensated in US. The compensation is not at all standardized in private practice. In public hospitals, again, whether you are a surgeon, super specialist surgeon, transplant surgeon, or a physician, the salary will be the same. So the compensation will be same. That way, it is actually beneficial if you do ID fellowship at least, and that way you're not working, like you're not doing surgery. The pay is equivalent. Other thing which I wanted to come to and discuss with you is that, which is very rarely discussed, is that nowadays we are, because the DM has started, a lot of microbiology graduates are also taking up ID specialty. The graduates who have done microbiologies. So what is your opinion about it? I know it's a controversial area. I mean, it has not been very well discussed in most of the ID forums in India. Should a microbiology pass out become eligible to become an ID physician? What is your opinion about it?
Yeah, this is a very important area now. ID is at crossroads in India. There is a younger group of physicians who are ID, like your generation of IDs, as the older generation is slowly fading away. But your generation is all formally trained. Your previous generation is not formally trained. Most of them are self-styled, excellent bedside clinicians. And that generation is slowly fading away. Now, how do we sustain ID in India? We all recognize ID is a imperative, much needed specialty in India. But how do we keep it going? How do we promote it? That's the question. Now, India, the government has come out with various training programs DMs and FNBs and diplomas and so on. I wish all that is streamlined properly and have just one or two areas rather than multiple different areas. Time will eventually straighten it out. Now, as for the people who are choosing, like you said, we need to advertise the availability of ID as a subspecialty. Many, many, many physicians do not know ID exists. Like one of your colleagues in India, Nambi, did a survey, and that he presented that survey in one of the ID meetings, demonstrating how few Indian physicians knew about the existence of ID as a subspecialty. And that was not that long ago. And I'm sure still that is the case. Many people do not know ID exists. So we need to promote ID. We need to be better communicators, especially when we are involved in public health and population health. We need to be at the forefront as good communicators. We need to be able to go to meetings, talk about our specialty, talk about the relevance of public health issues, talk about vaccination programs. And these are all our job. So we need to know to let the public know ID as a subspecialty is brand new. In India, ID was dominated by clinical microbiologists because of the British system. Old system did not have ID, but even in Britain today, ID is a separate subspecialty. India took some time. So microbiologists felt they could practice ID, which was wrong because they did not have clinical training. But fortunately now, ID has become a subspecialty. There are IDs, but it's coming very, very slowly. To go back to answer your question, would I promote clinical microbiologists taking up ID? The answer is absolutely yes. I will. Why? Because we don't have enough ID people. Let this proliferate, let the numbers increase, but we have to be rigorous. The same clinical microbiologist cannot be allowed to touch patients if they do not have adequate clinical training. So we should expect them to have damn good clinical training, bedside training, not sitting in the lab, going to look at the patient, talking about differential diagnosis, ability to elicit a good history, and those should be challenges for anybody who wants to be trained in IT. But clinical microbiology is a bonus. That's good. They have excellent base knowledge, but we will provide them with good clinical skills on top of it. Then why not? They should practice IT.
Actually, I was of an opinion. I mean, few years back, I was opinion that microbiology graduates should not be doing ID training. But then I joined this place where I am currently working, Rajiv Gandhi Cancer Institute, and I saw a lot of pathologists getting trained for clinical hematology, hemonc, and I seen a few of those fellows actually excel in their specialty because they have a very good baseline underlying pathology training where they can actually go down to the lab, do the stains, and they can identify, I mean, cancer cells, leukemia cells immediately. A clinician will struggle in doing that, and plus they get good exposure of as a clinician, they get a good exposure. By the time they come out, they're actually very, very good. So my opinion also started changing. I also believe that we should definitely promote clinical microbiologists joining ID specialist, and their microbiology knowledge has they have a basically heads up start from what we had in my time. I was not at all aware of what is how to do a gram stain, although we have learned that in MBBS, but we didn't do it during our residency. So it was I think it's a good start that we have a good clinical microbiology to start with, and then obviously we need good like clinical exposure, bedside exposure to become good ID physician.
Every ID person who has come here to train with me, who has come from India, who is basic clinical microbiologist, has been an excellent ID clinician as well.
Totally agree with you, sir.
And it's not magic. You can learn. You can learn ID medicine. So we are in a desperate need of doctors, ID physicians. People are not going into ID. In this situation, if somebody says, I want to do ID, Why would you keep that person away? You say, please come, but we will train you and we will expect nothing but the best from you. So everybody should be welcome.
I want to just briefly discuss with you about one aspect of ID, that is collaboration. I think you mentioned in many of your statements that we need to collaborate with other specialties. And I remember Dr. Mayur Ramesh, one of your students in Detroit, he when we met him, like during our observe, he said, when Chandra says jump, everyone jumps, and when he says sit tight, everyone just sits tight. So what he means was that whatever not like specifically in that way jump means jump, but if he says this we should do this, then all the team agrees, and those teams are not like physicians; they are transplant surgeons, hem-onc specialists, medical oncologists. So how do we achieve such a level of cooperation which you have achieved with other specialties, such a level of respect, particularly when you are managing complex cases like hem-onc patients, post-transplant patients, surgical patients getting complicated surgeries? How do you achieve that level of cooperation? I mean, obviously, it will take some time, but still, what are the pearls which you can give to us?
You need to develop as much gray hair as I do. Then you can. Now, it's not an easy question. It's a tough question. It's a matter of time. Your relationship with these other physicians, and making them aware that you care for the patient. You care as much for the patient as they do, if not more. You're there before they're there at the bedside. The patient knows your name better than their own physician's name. If they get that impression that you really care for their patient, number one, you go down to the X-ray department and discuss the case. So they know that you're really caring, and you know the details that they themselves may not know. So caring about the patient, as demonstrated by your ability to know all the details about the patient, impresses on people gradually. And they watch you practice medicine. They see how much you care for the patient, and they see success of your management, and it's a teamwork. And then of course, you're also doing your own research, you're publishing, your presence in the community is growing, your reputation in your field is gradually enlarging, and people become aware of that. And it's a combination of your reputation in the field, your ability to care for the patient, and your ability to communicate with the people and not being egotistical. Gradually, with time, you win them over.
Actually, collaboration is a big issue in public health hospitals in India. I worked in public health hospitals, and most of the time the interdisciplinary meetings do not happen. Most of the time, either patient gets shrugged off from one specialty to the other, and the discussion which should happen between two specialists does not happen at all. So collaboration is a big issue in India. And
absolutely right. It's here too. It's no exception. People have egos. People don't have time. They have to make money. To have an interdisciplinary meeting is almost impossible. And they don't even think about it. So many times you have to force these meetings for the betterment of the patient. Yesterday we had a patient. This is a 23-year-old girl who had laryngeal papillomas since birth. Laryngeal papillomas. And do you know why she got laryngeal papilloma?
No,
because her mother had warts in the genital tract. So it was human papilloma virus this baby ingested in the birth canal, and subsequently she developed laryngeal papillomas, which descended down into the lung, and she developed squamous cell carcinoma of the lung at the age of 22. Okay, so here is this frail woman who keeps coming into the hospital. ID gets involved because those papillomas get filled with pus, and she presents with lung abscesses periodically. And the squamous cell carcinoma, the oncologist keeps giving chemotherapy. And she's frail, she can barely eat, she can barely get out of bed. And imagine the quality of life for this 23-year-old. And she's got extensive laryngeal papilloma. So far, nobody has gotten together to form a multidisciplinary meeting to say, what is the quality of life? What is the end game in this patient? What is truly achievable? What should we be doing? So even in America, those things, bad things happen. So there has to be, so anyway, so the same thing in India as well. You need to have multidisciplinary groups making decisions so that best decisions made for the patient. Speaking of multidisciplinary, I want to mention pharmacy. Pharmacy should become an important aspect of infectious disease practice. It is already happening in America. When I start rounding, very frequently, I have a pharmacist on my team. And the pharmacist, as you may remember, they provide invaluable service on the team about drug doses, drug choices, drug interactions, and changing from IV to PO, early discharges from the hospital, monitoring levels, and they provide invaluable service to the ID team. That is non-existent in India. India is several years behind in recognizing the value of clinical pharmacy in the practice of ID, particularly if you're talking about antimicrobial stewardship. It's a long time coming. I hope Clinical ID Society takes the leadership and promotes clinical pharmacy to be recognized in ID teams and promoting more and more pharmacists to take up ID as a subspecialty and join ID teams. Once again, corporate hospitals have to take the lead in providing compensation for such a profession.
In the last SITSCon, sir, we had a workshop in which we invited a lot of clinical pharmacists as a faculty. So and they had a nice session. I remember meeting one of them, and they have also formed their own society now. I mean, they've started doing various online webinars and all. So it's coming up slowly and slowly. It's coming up. I'm also involved with ICMR for AMSP projects, sir. So in that projects also we are promoting that at least you should have one clinical pharmacist in your hospital if you're enrolling for the project for AMSP. So in that way, slowly people are recognizing the importance of clinical pharmacy, and I totally agree with you, sir. Because a lot of not just AMSP but also interaction issues with various drugs, which is very difficult for a single clinician to get hold of, and sometimes they forget to check. Like I remember when I came into this hospital, oncology hospital, they started using venetoclax, which is a good therapy for leukemia. And one of our patients got TB, so we started him on rifampicin also. We were not aware that rifampicin interacts with venetoclax. So only after we made a mistake, then we realized that there is an interaction with venetoclax, and we obviously avoid concomitant rifampicin with venetoclax in that way. So, but this is because it was a new drug for us. The hematology guys, neither me was aware of what is venetoclax. So the interaction issues became quite significant in that patient. So that way. Yeah. So that's why pharmacy is definitely a very equally important branch for AMSP and appropriate antibiotic prescriptions. So I think, sir, we are coming to the end. Like we have already spent almost an hour now. So just giving an open-ended question. Anything? I mean, you have obviously beautifully described what you think should be done from Indian point of view to increase ID residents taking up ID. But anything particular which comes to your mind, which is unique, like. One thing which I wanted to always ask about is that antimicrobial stewardship is something is going to come a big time in healthcare in developing worlds, particularly where cost is a big issue. Like every time we have to counsel the patient not only about the patient's health, also about the cost also. So AMSP, I think, is going to catch up quite early as compared to other aspects of medicine. So one thing which I wanted to ask is, how do I convince my hospital administrator for AMSP as a business model and not just an accreditation issue? Obviously, AMSP is required if you want to get your hospital accredited. But if you are not looking for accreditation alone, how do you make hospital administrators who understand business much more better than us into getting into truly into AMSP?
That's a good question. I'm not a businessman.
How does it happen in US, sir? I mean, in that way you can go it.
Yeah, in the US, it's a different system. There is a committee in the hospital, and the committee decides what drugs should be in the formulary and for what reason. And usually it is led by physicians, not by administrators. Administrators will be part of the team, but they are not the ones that will make the decision as to what's best for the patient and in that setting. So we decide on the formulary. According to the formulary, we'll stock the medications in our pharmacy. And accordingly, the medications will be dispensed, and each medicine will have its own indications and criteria. If the criteria are met, the antibiotic will be prescribed and released from the pharmacy. If the criteria are not met, they will talk to that physician who prescribed it, and he will be told, hey, this patient doesn't meet the criteria. This infection can be treated with cefazolin. You do not need a carbapenem. And accordingly, the person will be told. But if the criteria are met, then the drug will be released. And it's a process, and that kind of a strict process has to be in India too. But in India, I understand a lot of the hospitals have pharmacies, and they have a self-interest in selling an expensive product in their pharmacy, which defeats the whole purpose. So the hospital needs to understand selling the product should not be the priority. Appropriate drug therapy should be the priority. So if the physician prescribes cefazolin 10 times over a carbapenem, that person should not be punished. That person should be appreciated because he's practicing good stewardship. So that is directly contradicting the corporate hospital's goals if the goal is to make money. So that is a problem that one has to deal with. Now,
I think, sir, in that way, sir, our specialty in India, actually, what is happening is that the concentration of the quality of care has to come up rather than on the just on the business model. So, but I think over the course of time, I mean, again, just not much of an experience, but over the time, I've realized that people have started realizing the quality of care which comes with the AMSP. It leads to decreased length of stay, decreased secondary infections, and all those things, which actually in a long run become beneficial for your own patients. Even if you look into from business point of view, it looks much more better. I mean, that things needs to be ingrained into the business, hospital administrators, so that they take up AMSP in a much more serious way rather than just doing it on the paper that way, sir.
Absolutely. Patient care trumps everything else. Quality of care trumps everything else. Another area, before we run out of time, before we go off, is I wanted, some of the audience here may be people who are in medical schools influencing curriculums. How do we make people appreciate ID and microbiology? It has to be introduced in the medical school curriculum. Unfortunately, the medical school curriculum in India needs a lot of revamping. It is ancient. It is time it is visited and it is redone. Infectious disease should enter into a third-year medical student's curriculum. And we should be giving lectures, not the microbiologists who are sitting at the bench, but infectious disease clinicians should enter the medical school and make the student understand the relevance between what he's doing at the bench with the microbiology, how it is relevant to the patient. That connection should be made aware of for the student, whose eyes will open up and say, oh, there is a specialty called infectious disease that brings clinical microbiology to the bedside. That awareness is non-existent in India today. Infectious disease doctors play a very little role in teaching medicine at the medical school because the curriculum doesn't exist, or the curriculum is dominated by microbiologists. So we need to make students aware as young graduates, there is a specialty called infectious diseases. And it is an interesting exciting branch.
Sir, I think you must be aware that our National Medical Commission (NMC) has made the chapter on AMR and AMSP compulsory now. You have to get that certification done. Before that, you can't get your internship completion certificate. So only thing remains is that who will teach that, because there are no ID physicians in medical, very less ID physicians in medical colleges. So that's an issue. And
Yes.
I mean, I say SITS member, I can say that we are running a PG postgraduate subcommittee also. So in which we are currently doing online webinars, but we plan to go to medical colleges and get into this third year medical school for final year medical school, and then probably get introduced to them the ID specialist or the ID physician. What do ID physicians do in that way?
Absolutely.
I think, sir, I am afraid I will have to stop this session because I think you have to start your day as well. I have plenty of time, but I think you will have to start the day, so I will have to end. Any ending notes, any ending thoughts, sir, before I
Now, my ending thoughts are, first of all, thank you for asking me to be a part of this chat. Excellent. I enjoyed it. And you did it with a lot of maturity, and you put up with me. And that's great. I think infectious disease is there to stay in India. It's in good hands. SIDS is a very useful instrument, and SIDS members should take it upon themselves to be good advocates and ambassadors for the society, and spread the word in medical schools, youngsters, high schools, to talk about sexually transmitted infections in high schools. The sky is the limit. The responsibility for the ID guy in influencing public health and population health. No other specialty has this opportunity or has this responsibility. So you should be blessed and be thankful that you're an ID physician, and make the best of it. I can tell you, I'm in my 70s now. I don't have a day of regret of becoming an ID physician. It has been a joyful ride for me. And any day I will take up ID over and over again. Thank you.
Thank you, sir. I would like to thank him and our listeners for his time. And he has always been available to us with his knowledge and wisdom. And we admire him for his ever-learning zeal. I mean, still he has that ever-learning zeal. He wants to learn new things, and his down-to-earth nature, which is something which is very unique, and we should imbibe from him. And I hope this session will enlighten the current and also future ID professionals, or also pave way for more and more such interesting sessions. We hope that we do a webinar taking this chat as a base, and then probably include more Indian ID physicians and chat about it in a much more elaborative way. Thank you, sir. I'll stop the recording from here.
Thank you. Bye-bye.
Thank you, sir. I think we are Kushal, we are live.
Yes, sir, we are live.
So I hope this chat with Dr. Chandra was enlightening, and I hope it did the purpose of giving the present and past of the future of the ID physicians. And we do not hope we actually have a live panel discussion with us. And one of the peculiar things or takeaway from this chat with him, with Dr. Chandra, was that I thoroughly enjoyed chatting with him. And I particularly liked one statement which he mentioned, how to collaborate with other specialties, mentioned about keeping patients, developing some gray hairs, taking care of their patients, and knowing them much better than the primaries. This certainly changed my way of thinking and my way of functioning on a daily basis. So on this note, I would like to begin the panel discussion. I think Dr. Chandra has also joined us. Hello, Dr. Chandra.
Hi, can you hear me?
Yes, sir, loud and clear.
Very good, very good. What time is it there? It's in the evening,
close
right?
to 7:45, sir. 7:45.
Okay. So it's 9:15 here. I'm at home right now, so I wanted to finish this and then drive over to the hospital. So anyway, I'm happy to participate, and I see Abdul Ghafoor there. Hello.
Hi, Chandra.
Hi, Arvind there, I recognize, and Vasant
Good
there.
evening, sir.
Hi guys, thanks for having me. And let's begin.
So on this note, I'll begin the panel discussion. Just to inform everyone, we are currently being listened to by around 205 delegates from the Zoom link and close to 50 to 60 people on YouTube Live. I will begin with the introduction of the panelists. The first panelist is Dr. Deepak. He's an associate professor at the Division of Infectious Disease and in Department of Medicine at AIIMS Jodhpur. AIIMS Jodhpur has a DMID program and he's the course coordinator of that program. I welcome him. Dr. Arvind, he's the HOD or Head of Department of Infectious Diseases at Government Medical College Trivandrum. Welcome him, sir. Welcome, sir. And Dr. Kiran Kumar, he is a senior advisor in medicine and infectious disease in Army Hospital, RNR, Delhi. Welcome, Dr. Kiran. So I'll start with where I left, and I think I'll go obviously you can't discuss past with such young people, young panelists. So I'll discuss present and future. So this is a question to all the three panelists who are practicing ID currently in India: is how do you collaborate with your specialty, with other specialties in your hospital? What challenges do you face, and how do you sort out these challenges? Just to open up the discussion, Dr. Arvind, can you start?
Good evening. I would like to thank Hema Declaration Trust, especially Dr. Nidin, for this opportunity. I work in a government medical college, Trivandrum in Kerala. Regarding collaboration with other specialties, I joined medical college in 2011. So initially we had certain challenges, but just like Chandra sir said, and later, we need to spend more time with the patient, and the patient need to be more familiar with us. And over the last 5 to 6 years, the collaboration has never been a problem with me. So we collaborate with almost all the departments, including neonatology, gynecology, as well as we have the regional cancer center, as well as Srijitra in the same campus. So after we gained the trust of the clinicians belonging to other departments, now collaboration is not an issue at all. And being the medical college situated in the capital city, we do collaborate with all other government as well as private institutions across the state as well. So collaboration per se, as Dr. Nidin mentioned, has difficulties in public scenario, but since I come from a medical college where the ID department was there from 1992 onwards, so of late it has never been a problem with us. So the service we render to the other departments is being appreciated, and so it is in one way easy going for us.
Yeah, it's actually nice to hear that it's easy going for you in a medical college regarding ID in India. Dr. Deepak, can you please
Yes, sir.
tell us your experience?
Yes, sir. Yeah, I think we have initiated this Division of Infectious Disease and DM program 3 years before, and definitely we got lot of resistance from all the department when we are going to say कि you have to act like a way. So what we have did, we first contacted with the head of the department, and we have take a time. Please listen us. We will have 1 hour or 2 hour discussion, and after that you will decide should we have to intervene your ward or in the ICU. And what we have saw that after the repeated discussion of 2 or 3 times, then they can only able to collaborate or able to call. And from last 3 year, almost every clinical department we go and discussed. And yes, it take time, but with the time now we are getting the very frequent call from all the clinical department regarding the ID or any other problem when they are not able to deal. So definitely at the day one, no department want to accept the infectious disease physician, especially when you are going to say, okay, we are changing your antibiotic, or you are giving wrong antibiotic, or you are giving wrong dose. But with the frequent interaction, they can able to accept us. This is the our experience with the collaboration.
Sir, Dr. Kiran, can you please elaborate your experience on how have you gone about in Army Hospital, RNR, quite big referral center for the Army people?
Good evening, all. Good evening, Chandra sir, and thank you, Nitin, and thank you, Gafur sir, for this opportunity. So let me be straightforward. I just completed my ID physician ID 2-year fellowship from Apollo Hospitals under Dr. RJK and VRS and Gafur sir, Nambi sir, 2018 to 20, and I landed up in Army Hospital R&R, New Delhi, straight in the COVID pandemic. And my first question to me was, what are you? So, are you a breed of mix of community medicine and microbiology? That was the first question posed to me. So, as everyone said, I also did not receive any great support. But what I will say was the surgical specialties approached me. They wanted me to manage their cases. And I would be, in fact, thankful also to say to the nurses, especially in the CTPS ward. So they would see 2, 3 antibiotics and they say, "Sir, we need to call this guy. Just call him and let us sort it out." So that's how I gained the collaboration. So the surgical specialties were more forthcoming and they were more listening to me. I had the critical care people who got trained in various other places in India who were aware that ID is a specialty and they were interested in me. They were interested about on aspects of infection control, on hand hygiene, on prevention of carbapenem resistant bugs, on strategies. In fact, as Chandra sir was talking about a clinical microbiologist. In fact, this particular drug, I would like to say this particular drug, ceftazidime avibactam. So when it came in 2019, 18, 19, and 20, so there was a lot of brahua about it. And I think Nitin has also written a paper how ceftazidime avibactam has now become a dustbin of a sorts, or is it losing its relevance? So I was the one who convinced the microbiologist, sir, let's do this test of seeing the synergy, and then giving it to the clinicians. So the clinicians were very surprised. What is this drug that Kiran Kumar is getting? I said, there's no drug, no new drug, sir. It's just drug has come up. Only thing is I'm just regulating it. So we could regulate it about for 2 years, but then again, it went off our radar. So sometimes as an ID physician, I feel very good, but sometimes I also feel guilty that probably we as ID physicians introduce drugs and then they get diluted in the subsequent efforts. So initially I was totally unwelcomed, but slowly I still have a lot of resistance, still lots of works to do, but the surgical specialties were more forthcoming for me in this way.
Actually, COVID helped me in my own practice also, and now I can say that I'm quite well established at one place. But definitely, COVID helped, and slowly, and as Dr. Kiran said, I was not welcomed at all in the management of cases. And slowly, when people saw the work of an ID specialist, what importance they can say, then started people. I remember, I will just recall one of the I had a big fight with one of the junior consultants in Himong when I joined the place over overuse of antibiotics. And then subsequently 2 years I worked with her. And then when she went out of the hospital, she went to some other place. She specifically came to meet me and said that now after seeing you, I realize that actually there is the importance of ID in Hemong. Before that, she was like very confident, we don't need Hemong. Why are you even coming to the transplant unit to round? So these kinds of experiences are quite common, I think. So everybody would have faced some unwelcoming comments or unwelcoming, sometimes even offending comments by your colleagues. But then slowly people realize that IDS specialties cannot be excused around. And it is one of those specialties which cuts across all these specialties, and you can tend to meet a lot of different kinds of people, and we have to go around with that. I will take the base from what Dr. Chandra spoke in his chat with us. And he spoke about that if ID is not a known specialty in India, then probably ID specialists needs to take more and more lectures in undergraduate programs and postgraduate curriculums. So now all the three of you are working in medical colleges. Dr. Yupak is working as a course coordinator in DM. Do you actually go around? Are you a part of routine undergraduate and postgraduate training in your medical colleges? Is that become a norm now, or still the clinical microbiology takes the lectures on AMR, antibacterial stewardships, and other things? How is it? How does it? How has it changed after the infectious disease department has opened in medical college?
Yes, after the initiation of infectious disease department, we have taken the regular classes especially for the common how to syndromic approach, how to use antibiotic and what are the stewardship. We used to have some integrated teachings every week. So we have to integrate with other departments. So we are taking a integrative teaching along with the microbiology for all the postgraduates from starting from third semester to the at the uh, ninth of semester. But we have started recently from last 2 to 3 years, and I have also suggested to our academics that we should incorporate the infectious disease is a curriculum, because there is as Dr. Chandra sir said, there is no separate curriculum for infectious disease in final year, and the final year is the deciding phase. Then we will decide where I should I select the infectious disease or not, because in India we have also started some 6 year courses like in AIMS Delhi, 6 year infectious disease courses. If the final year MBBS student is aware about the infectious disease, so they can able to select the infectious disease as a specialty. And we are also planning to start the 6 year courses in our institute also. So yes, we are taking the classes for the infectious disease for all the semesters.
That is a very welcome step, and I think this is something which is very much required. Dr. Arvind, is it the case at your own hospital also, your own medical college, or something else?
Actually, in Trivandrum Medical College, we are not MBBS teachers, to be frank. We are not MBBS teachers. We do have the medicine residents, microbiology residents, as well as the community medicine residents. They have, posting or rotation in infectious disease department. This used to be the storyteller around, say, 4 years back. And then I think Chandra sir said that our curriculum is ancient. But then, as Nitin said, recently some changes have come in. So it has become, say, competency-based curriculum, something like that. And then they have this elective rotation. The elective means that the specialties which are not part of this undergraduate curriculum, like infectious disease, gastroenterology, cardiology, etc. So we have to give some topics, and these students can select from these topics, and then they will be with us for 2 months, 2 weeks. That is the electives. So from last year onwards, now ID also has we also give some topics like approach to fever of unknown origins, antibiotics stewardship, like that, and students take these electives in ID. And last year we had around 10 students doing electives with us, and they were really impressed with ID. So that even after these 2 weeks were over, they came back to us to learn more about medicine. As of now, this ID part in this Davidson, etc., is being taught by medicine. But since we do collaborate with the microbiology department, so our microbiology department is acting like clinical microbiology, and they are teaching the MBBS students more about the clinical microbiological aspects as well. But to your question, whether we are teaching, the entire aspect of ID to MBBS students, the answer is no, because in the curriculum, ID is not part of this MBBS curriculum, MBBS. Then regarding this antibiotic stewardship, which is part of this the MBBS curriculum, those aspects unfortunately is being taken by the pharmacologists who are not really clinical pharmacologists. That is the problem. But to interact with more with the house surgeons as well as MBBS students, we have started an app. App has been devised by our medical college to interact with MD students, MBBS students, and all. It's a self-learning sort of app through which we give case scenarios and teach the students the concepts of antibiotic stewardship. Even though we are not formally teaching them antibiotic stewardship as ID persons, through this app we are engaging with all the MBBS students as well as interns and the MD residents from all the clinical specialties.
Dr. Chandra, please, if you want to comment on anything, please feel free, because I have already chatted with you, so it looks like I have run out of questions for you. But if you want to have a comment on anything which we are discussing, please feel free to comment on.
No, thank you. I'm listening to all of them. What I sense is that, first of all of them are fairly young, the discussants here, and I sense optimism in their voice, in their thoughts, which is very, very important, because we are all facing an uphill task. Whether ID is going to survive in this environment, how do I establish ID? Is ID going to be around, or is ID going to be displaced by other forces around? So you are the guys that have to keep ID alive and come up with ideas how to convince your administrators to recognize ID is an important part of your institution. Each of you have different set of circumstances, different set of challenges. So you have to come up with your own ideas how to deal with those challenges in your environment. You need to have the support of the administrators. You need to have support. You have to be able to get into medical schools. Arvind was talking about not being able to in the medical school. I'm talking about getting into the undergraduate curriculum and talking to whoever in politics, in government, to make them realize that we should be designing the curriculum for the undergraduates. That's what we are doing at Wayne State here. I go to the medical school, I teach the second year medical student. I took it away from the clinical microbiologist. I present cases and I discuss the relevance of a gram stain, relevance of a chocolate agar positive culture, and I bring it to the bedside, which the clinical microbiologist is unable to do. But to make that happen is not easy because it has been the domain of clinical microbiologists. How do we take it away from them without hurting them, without making them realize this is a joint effort? This is not one or the other. It's both of us doing at the same time. So it has to be done with diplomacy, tact, but you should be able to get into the undergraduate level. I'm very glad you are able to do it at the postgraduate level. But remember, undergraduate level is critical if you want to emphasize antibiotic proper uses and stewardship and infectious disease as a branch. Otherwise, if I'm just estimating, about 40 to 50% of doctors in India do not know ID exists. I'll stop there.
Thank you, sir. Thank you. I think one of the moving on from the teaching to the routine practice which we do in our ID. I mean, I work in a cancer center which is not a full-on corporate hospital, but sort of a private hospital which works for on third-party payments from the patients. So one of the major challenges which I face in my routine practice is non-compliance with my suggestions, and involvement of an ID department is quite late in clinical management of cases. So I feel this is primarily because there are no clinical pathways developed already in the books, in the textbooks, in the recommendations, which ask you to involve ID specialists as a mandatory service or even as a recommended service. So from experience from Dr. Arvind and Dr. Kiran, you work as close to the state government or at a high-end place where policy making is there. How do you think regulatory authorities from the hospital should formulate their policy so that ID department is more inclusive into managing those cases where ID department should have been involved earlier rather than being late or the last moment? Dr. Kiran, can you elaborate on this?
Basically, I still feel, there's a word called Abhayahastam. The administrator should actually have an Abhayahastam on the infectious disease specialist. So he should, I mean, I think the ID specialist should be given should be handheld, at least in his initial formative years. I think that's where the sensitization of administration would come in. See, in the COVID, I could manage that to a great extent. Even though, see, when I first went into the army as R&R, I was actually doing testing, contact tracing. In fact, I was the only one guy to go around. People were all calling me. So the administrator grew very close to me, and I was able to tell my vision, my problems. Even though they were listening to me, yeah, they were not. That was not the initial priority. But later, then they came back. Then they formed a hospital infection control committee. I was involved. We didn't have a clinical pharmacist, or we didn't have anything, but we had a microbiologist. We were doing on the rounds. There were certain things we were giving points, but the points were not getting acted upon. But at least we did made a start. But I think my feeling is that the administrators should be listening to us, and the onus lies on us to make the administrator listen. I know it. You have to keep bugging them, keep going on to their offices. Just be staying there, sir. I need this. 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 And finally, they will listen. And I keep on telling, because I had this problem of Burkholderia in my hospital. So we said we need to do this, we need to do this, we need to see the water source, what is coming on, what is there. So many solutions came up, whether they were getting done or not, but at least someone was listening now. But it took me 2 years to do this. So I'm still hopeful, but I think we still require the administrators to listen to us, and the onus for the administrator to listen to us again lies on us. Very painful thing, but I think probably you just have to stick around like a gum. Anything like point from Chandra sir on this, sir?
No, I think, it's we have to make the hospital administrators realize that our contribution is unique, that is not matched by any other specialist. And our contribution translates into dollars or rupees and cents, because that's the language administrators understand, rupees and cents, not patient care. Patient care is secondary, unfortunately. So if you can come up with strategies to show that your approaches to patient care, your approach to stewardship will actually save dollars for the institution or save money for the institution, that's the language the administrator will understand. So we have to be able to speak in their language so they will understand having an ID person on board is beneficial to them.
Thank you, sir. I think I move to the next part of this discussion. He also spoke about that microbiology should be encouraged to train as ID physicians. I think it was a little in the middle part of the chat which we had with him. And Dr. Deepak, you are a course coordinator of the DM course in AIMS Jodhpur, and I know that some of the microbiology PGs have joined DM course in your hospital. So what has been your experience in training them into clinical aspects of ID? And to all the listeners, some of the microbiology PGs who want to pursue ID may be listening to us. So how difficult is it for them to adapt, and how do they adapt? And similarly, how do medicine PGs adapt to the microbiology aspects of ID? Can you please elaborate on that?
Yes, sir. I think I have got excellent experience regarding this. What we have did for the eligibility for DM infectious disease program, we have kept a separate seat for the clinical department, like for the medicine or from the tropical medicine or from the pediatric, or one seat is from the for the microbiology. So in most of the our student, we used to have one pair, one from the microbiology and one from the medicine. So, as a course of DM infectious disease, I think this combination is work excellently. So, we have a very excellent communication with the lab. We have very excellent inputs from the lab as a clinical microbiologist in the DM program, and a very good clinical input from the person from the medicine. So definitely there's just some initially there's some difficulty of a clinical microbiologist to become a full-fledged physician, because he or she are not trained as a physician to diagnose a cardiac, diabetic and other autoimmune diseases. But as a ID consultant, if a clinical microbiologist work with a team, I think he or she can work an excellent DM uh, or ID consultant in a team rather than a separate ID physician. We can said a ID expert of a clinical microbiologist rather than ID physicians. So we have make a model like this, and I think it work very excellently. And I think in the area of Rajasthan in the west, fortunately, our institute has recognized as a good infectious disease consultants because of the this combination team of the clinical microbiologist and the physician in the DM program. So we can able to teach them, and they can work as a in a team rather than a separate ID physician. They can work very well in a team to give ID consultation. As Chandra sir said, we require more and more ID person to teach the physicians and surgeons and the transplant unit, rather than we require a separate ID physicians to work only in the OPD. We require more and more ID consultant to work in the hospitals to improve the patient's care.
Thank you. I think that is the message which we should pass on from this webinar, is that we need more and more people to take up ID, and if someone is willing to take up ID, then why not? Why should there be a roadblock for that? So moving on, I think Sir also spoke about that. What are the other non-clinic or role of ID specialists outside the clinic duties? And a lot of off late we have seen a lot of outbreaks which has happened at a hospital level and as a community level. I mean, unfortunately or fortunately, Kerala has been on the top of the list. Nipah, Zika, monkeypox, or everything has started with Kerala. And I know Dr. Arvind has been personally involved in managing all these things. So what is your opinion about of a role of an ID specialist outside routine clinical duties? Not only outbreak management, that is part of the clinical, but also other than that, antibiotic policy, running AMR program at a national level or at a state level. So what are your opinion about it?
I think we have a very important role as a leader. For example, in October this year, WHO said that participatory antimicrobial stewardship. Participatory means that we need to take this antibiotic stewardship concept to the public. So it should be done by the ID person. Microbiologists cannot take this antibiotic stewardship concept to the public, and we cannot means expect the public health professionals to take this antibiotic stewardship concept or participatory antimicrobial stewardship to the public. So we are the best persons, to take all these concepts about infection prevention, control, as well as antibiotic stewardship to the public. And since I'm working in medical college in the capital city, for the last 10 years, I've been part of a lot of government committees. I'm the nodal person for infection prevention, control, as well as antibiotic stewardship for the state of Kerala, part of state RRT, part of the, the One Health. I'm a technical person for the state One Health, and a member of the COVID medical board, the Nipah medical board, the SIC, and all those stuff. So we are involved in framing all the state guidelines, maybe COVID guidelines or Zika guidelines or Nipah guidelines. We go to the ground level and take part in all these outbreak control activities. And since we are engaged in this, during the COVID time, as the Kiran sir, etc., said, COVID was sort of a game changer for us as well. Because since we were involved in framing all the policies and the guidelines and all the ID person in other medical colleges in Kerala were also made the nodal persons for the COVID control activities. And so this ID became sort of a home name for all the doctors in Kerala came to know that ID is sort of a niche specialty sort of thing. So we have a role to play in a lot of activities outside the clinic as well. And we got more recognition for the activities we did outside our clinic than the activities we do inside the clinic. So means if you are part of framing the policy for the state, you will end up saving maybe say a lot of lives more than you are going to save in the clinic. So in that way, ID plays a huge role in formulating all the policies for the state government with regard to the infectious diseases. For example, during this World Antimicrobial Awareness Week, in the state of Kerala, this antibiotic detrite Kerala, the concept is there, and that is also led by the ID persons in the state of Kerala.
Dr. Kiran, your opinion on this? You are on mute.
Sorry, I agree with Raghu sir on this. But in my hospital or on the outbreaks issues, we don't deal so much on that. But I can say one thing on this. One thing is, whenever these outbreaks happen, I'm the first one to get an awareness into the people there. So even as I think I contribute that way, that as an ID physician, at least sensitize the environment. Listen, this is what is happening. So now my MD students start discussing what is difference between Zika and dengue. Then they will say, okay, one has more red eyes and one has less red eyes, and that way, that kind of context. And suddenly we were told, okay, how do we procure the drug? And that the talk was happening on that level. Suddenly the monkeypox scare was become, I think Delhi had about 10 to 11 cases. You were there already in that. So there was a lot of happening. So whenever outbreak used to happen, at least they would come and talk to me and ask what is happening. And I would get inputs from more from the ID physician Kerala. So that way, as a community, I grew up with ID physicians, being an ID patient with close-knit ID physicians this way. We thank the Kerala ID group for doing such fantastic work and actually sensitizing us and giving us more knowledge on these things.
Yeah, actually, COVID actually
May I
was
say something?
blessing in disguise. Yes, sir. Please, sir.
This is a very important area, public health, where ID physicians can play a big role, where the clinical microbiologists cannot. So this is a thank God for the pandemics. We have been offered this opportunity to come to newspapers, television, media, and we are being asked to come for interviews. So this is a God-given opportunity to advertise ourselves, that we exist in the hospital and in the public health environment. We take leadership in identifying these outbreaks and come up with solutions. And this is a brand that is unique, not for the surgeons, not for the clinical micro, but only for the ID specialists. So take advantage of this opportunity, number one. Number two, more importantly, nobody talks about vaccines. Vaccine is not an area of clinical microbiologists. Vaccine is not an area of surgeons, cardiologists, other subspecialists, but us. As you all know, vaccine is a very, very underutilized tool around the world. So when you're given this opportunity to be in front of television and radio media, make sure to talk about vaccines, prevention of infections. We have wonderful tools that are highly underutilized. And it is up to us to go to medical school, to go to high schools, to go to colleges and talk about the value of vaccines. It is up to us. That opportunity, unfortunately, is lost every day.
Yeah, I think, sir, talking about infections to younger people will also give an opportunity to advertise ourselves as an ID specialty, like going to colleges, non-medical colleges, or even going to schools, talking to students of class 11, class 12, and then subsequently to other colleges can also help us give us a public health view and give us more and more advertisement, sort of an advertisement for our specialty. That is very very valid point, sir. I think moving on to the discussion, I have to take two questions from YouTube also, but before that, I'll just ask one thing. Now, see, sir mentioned that they were before his times, they were ID specialists who were not formally trained, and in India also we have many of our own teachers who are not formally trained in ID, but they are excellent teachers, they are excellent physicians. But now, since we have moved along, and now we are living in 2023, we have various sort of programs around. How much of training is enough as per you? Whether it is 15 days, 1 year, 2 year, or 3 years of training. I mean, to give an example, CMC Vellore has a post FNB, post DM transplant ID program also. So how much of a training in ID is actually enough? And is there a need to regularize these trainings? Because some people have a 15-day certificate course in ID. They also can claim they are ID specialists. Some people have worked for 3 years. So they are also equal. Are they in equal? Should they be treated as equal or should they not? What is your view upon this? Can Dr. Kiran start if he wants to?
I'm somehow I get really flustered when someone says there's a 15-day ID course and people do it ID months and 3 months. I really don't know what they're doing in the world of ID there. So I think we should strongly desist this unstructured courses or this fly-by-night courses. They do more harm. I think as we should have some regulatory body, maybe. Say, I know we are in a very nascent stage, but there should be some kind of regulation where it can't happen. It's like fooling. I mean, let's be frank on that. It's like doing a cardiology 2D course and saying I'm a cardiologist. It doesn't work like that. So there's sweat and toil in ID. There's a sweat and toil. Unless you don't go into the depth of the cases and write case sheets and understand, go to the microbiology lab and analyze data, and literally go to the technician, the lab technician, the microbiology, and say, show me the plate. How does it look like? What does the colony like? It's actually, I think it's It's totally there if someone says who has done a 15-day course or something like that. See, refresher course is different, or a primer is different. But doing a 15-day course and proclaiming that it is an ID specialty or you've done ID is something, I think that needs to be stopped. That needs to be totally condemned.
Dr. Deepak or Dr. Arvind, if you want to have a comment on this.
Think, sir, I think to become a ID physician, I think the course should be at least 2 year, or better to be a 3 year. The fellowship course could be 2 year, or in a DM course should be 3 year. I think a course less than of the 2 year, I think it is not enough to become a good ID specialist. So what we have realized, it at least should be 2 year, and better to be a 3 year courses than to be a good ID specialist.
Dr. Chandra, would you like to comment on this, sir?
I agree with Kiran. We need to have formal courses. Informal courses are dangerous and detrimental. We should discourage informal courses. In the United States, we just have one. We do not have FNB, DNB, and MD and DM and all. You just have one. That's it. If cardiology can have one, why can't ID just have one? Why have all these other letters? Just because somebody couldn't get into a DM, they end up getting an FNB. All those avenues ideally should not exist. There should be one pathway. But there are practical reasons why these exist in India. So one has to juggle between these two concerns and come up with a medium course. Ideally, I would suggest one course. In infectious disease in the United States, for the last 50 years or so, a 2-year program has worked very well. So I think a 2-year after your MD general medicine should be sufficient to produce a good clinical ID specialist. I don't think a 3rd year is necessary. In fact, many of the people here claim 1 year of training is adequate and we should cut down 2-year fellowship into a 1-year fellowship. Because the 2nd year, if you look at the curriculum, most of them end up doing research. And those research things are quite meaningless. They end up publishing 1 or 2 papers, 1 or 2 presentations, and that they think is the end of their research, which I don't think is ideal. So I think to be a good clinical ID specialist, you need 1 to 2 years of intense training. I think a 3rd year is redundant, at least from the US experience. And I think they should be formalized and have as few degrees or diploma as possible and try to combine the 3. So everybody would be recognized uniform. But this is easier said than done.
Sir, it's a very tough question to answer. I understand that it may not be resonating with everyone who is listening to us, but still, I think I agree. We have to agree. There has to be a uniformity. Everybody will agree with us, and something which we can take from the specialty which has happened right in front of our eyes. Critical care, intensive care specialty. They also have started this 1-year course, and over the time they have also realized that the quality of training has been diluted. So now everything is getting converted to 3-year courses. But definitely those things needs to be formalized and made uniform. So I have to come to the end of this. So I'll take 2 questions from YouTube. Dr. Ravi Teja has asked us. I think sir is the best person to answer it. Can I do transplant ID fellowship in US after clearing my US MLE?
After clearing USMLE, generally you have to do internal medicine residency, and then you can do an internal infectious disease fellowship, and then after that you can do a transplant ID. Now, trying to do transplant ID right after USMLE is not the usual way.
So that's not possible, I think.
It won't be, well, if the transplant ID program, remember, transplant ID is not a board certifiable program. We do not have an American board exam in transplant ID. So if I have a transplant ID program at my institution, I can take whoever I want. So it's up to me. Suppose somebody from India after MBBS applies to me and says, I want to come and do 1 year with you. It's up to me whether I'm going to take that person or not. But that person will not get a diploma, nothing at the end of the year or two. So there is no hard and fast rule. But in general, if you want to do transplant ID, you should have completed your ID fellowship. I hope I answered that question.
Yeah, sir. I think the person who is asking probably has done some ID training and he wants to go to US and then probably come back with the transplant ID certificate or diploma like that. Probably that is the intention of asking that question. Second question was, I mean, you mentioned that in your chat also. Is there an increase in the infectious disease transmission due to climate change? I think you briefly discussed that. Can you please elaborate, or maybe someone else from the panelists can also come up with what has been their experience with regards to climate change and infectious diseases?
Yeah, this is, for those of you who had the opportunity to go to ID Week in Boston in October, there were a lot of sessions on how climate changes influence infectious disease around the world. We've seen diseases that are considered to be just tropical. Now, slowly they are moving northward and southward away from the equator to become temperate diseases. In the US, for example, there are 10 cases of malaria described in the United States this year. And none of these patients went outside the country. The mosquitoes have come into the United States and they are beginning to get used to the climate as the climate gets warmer and warmer. So we have Aedes mosquitoes here, we have chikungunya here, we have dengue here, and we have Zika here. And they are slowly moving down from southern United States all the way up to the northern parts as the temperature warms. So these are being described every day around the world. Countries that have never seen cases. For example, we never saw Lyme disease before. Okay, now we're beginning to see a lot of Lyme disease. What does this mean? Now I have to include Lyme in my differential diagnosis, not only taking care of patients, but also teaching the medical students and the medical residents. Why is this happening? Because people are going to the bushes, they're destroying the forests, so the ticks are slowly coming into the cities. The things once we were confined to areas because of the deforestation. This is not only climate warming, also other measures that we are doing as human beings, clearing areas where humans can expand further. So the things that were confined to forests are slowly finding their way. And I'm sure you've seen that in your own practice as well. So to make it short, yes, climate is only one aspect. Many of the other things we are doing in our lives, slowly making the things that were once considered not possible is beginning to happen. We used to draw a picture of United States and say, this is where we see histoplasmosis, this is where we see blastomycosis, this is where we see coccidioidomycosis. They were very clearly defined endemic regions. Now, we draw the whole picture of the United States. You can see any disease anywhere because things have moved around. Not only the climate influence, but a variety of other things that have happened as well.
Dr. Arvind, would you like to comment on this? I think you are the best person to comment from India.
I totally agree with Chandra sir. On a lighter vein, almost all the neglected tropical diseases like dengue and etc. are moving into the temperate zone so that it won't be neglected anymore. So we are having effective dengue vaccine, the chikungunya vaccine, the IXCHIQ has come up. So probably the best way for a tropical country or a underdeveloped nations is to have all these diseases reach USA. So in that way, climate change is helping us. But from our perspective, we used to have this leptospirosis, etc., only during the monsoon period. But now we don't have this monsoon season per se. We are having, say, a tropical showers like sort of thing all the year round. And we are seeing all these infections which are tied with this monsoon, there's a dengue or chikungunya and leptospirosis all the year round. Seeing more and more cases of amoebic meningoencephalitis coming up. That is also being tied with this the climate change. So climate is a change is a huge problem for everyone, including us. Yeah.
Thank you.
One
I think
example is this Nipah also. Nipah, I know
Yeah.
previously it was during the breeding season of bats was from December to May. Now we are seeing actually Nipah all the year round. So that has been described from Bangladesh. So we have to be on the lookout for all these sort of infections because of climate change.
This keeps the infectious disease physician on his toes all the time.
True, sir.
Also, I think for the listeners who are trying to decide whether we should take ID as a specialty, I think the discussion actually elaborated very beautifully that as ID physician has to be a good clinician. You need to have a good microbiology knowledge. You need to have a good knowledge of the politics. You need to have diplomatic skills. You need to understand the world also, what is happening all around the world. You need to have a good geographical knowledge as well as knowledge of what is where. And sometimes people will come and say that I have come from that city. You will probably have to know what city is this, what is more common in those places and all, and what is going on at that time. Like for example, someone is coming from Kerala to Delhi. I need to be aware what is going on in Kerala before I comment on anything on that patient. So these are the various aspects which an ID physician needs to dwell upon, and I think it's a fascinating specialty. Sadly, I have to come to the end of this, and I would like to thank all of you, especially Dr. Chandra and all the panelists, to spare some time out of your busy schedule and discuss this fascinating specialty. And I think it will benefit our specialty, and it will help the young ID physicians to choose the specialty in a better way, in a more knowledgeable way. They will have a more informed, they will take a more informed decision to state it that way. So I think I have to sadly say thank you to all of you. And I would like to thank Dr. Ghafoor and other trustee members. Dr. Vasant is also around, who have given me the opportunity to moderate this session. The link will be available in the YouTube also, so we can disseminate the link so that more and more people can watch this. Thank you so much. Bye bye.
Nitin, one thing.
Yes, sir.
I just wanted to say hello to Dr. Chandra, sir.
Hey, Vasant.
I'm
Good
good.
to see you.
Yes, how are you doing, sir? So
I'm doing very well. Thank you. How are you doing?
I also spent my 6 weeks with sir in 2011 during my stay in Main State as Nitin.
Yes. Remember going to the carnival? Yes.
Yes, sir. So how is Lina and ma'am? Good.
Everybody is doing very well. Thank you. Give my love and regards to your family as well.
Yes, sir. Thanks, sir. Have a nice day, sir.
Thank you, guys. Thanks seeing all of you. Infectious diseases is alive and very well in India. Among you guys, it's in good hands. See you guys. Bye-bye.
Thank you.
Bye-bye.
Bye-bye. Kaushal, can you stop the session?
Yes, sir.
Thank you. Thank you so much.
Thank you, sir.
It will be there it will stay in the YouTube, no?
Yes, sir.
Yeah. Okay. Thank you so much.
Good, Nitin. Good job.
Thank you, sir. Thank you for the opportunity, actually.
I'm not wearing my shirt, so I can't come.
It's not getting recorded now.
Fine, good. It will be on that, and also Mank's team will send us the video recording. We'll upload it on our YouTube also.
Yeah, sir, definitely.
Good.
Okay.
Good night.
Okay, sir. Bye, sir.
So just now, after an hour, I'm going to do a recording of Professor Hendrik Wegener. You know Hendrik Wegener?
No, sir.